Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having the International Journal Gynecological Cancer Fellows do the podcast for the special issue. We're really very excited to hear their thoughts on these important articles. The topic of the special issue is rare tumors and gynecological cancers. So we're going to start actually with Manuel Montesinos Albert in the Hospital Universitario and Politécnico La Fe in Valencia. And Manel, I would love to hear what were some of the articles that really stuck out as important and relevant to you, and what were some of the findings in those articles?
Hi Pedro, I'm most interested in the controversies in updates and controversies in the management of uterine serous carcinoma and uterine carcinosarcoma. Despite accounting for only 15% of endometrial cancer, uterine serous carcinoma and uterine carcinosarcoma are responsible for over 50% of deaths, largely due to their high metastatic potential with distant spread in up to 70% of cases. These cancers primarily affect older postmenopausal women and are strongly linked to p53 mutations, found in 80 to 90% of uterine serous carcinoma and 70 to 90% of uterine carcinosarcoma cases.
So now, given that the prognosis really has always been very poor for this subgroup, what do you see as the optimal treatment approaches for these diseases?
The gold standard treatment is a multimodal approach combining surgery, chemotherapy, and radiation. Surgery includes total hysterectomy, bilateral salpingo-oophorectomy, and lymph node assessment, often with omentectomy. Due to high recurrence risk, platinum taxane-based chemotherapy is preferred. The PORTEC-3 trial supports chemotherapy plus radiation for p53 aberrant tumors, while DOG 0261 established carboplatin paclitaxel as the standard for uterine carcinosarcoma. Radiation remains optional for local control but does not significantly impact overall survival.
So now I want to ask you, because a lot has been ongoing with regards to the molecular guided treatment of endometrial cancer. How can molecular biomarkers guide treatment in this disease?
Well, molecular biomarkers influence treatment decisions for uterine serous carcinoma and uterine carcinosarcoma. Mutations in the tumor protein 53 gene classify these cancers as having a high copy number and a serous-like profile, which is associated with poor prognosis. Overexpression of human epidermal growth factor receptor 2 is observed in 16 to 47% of uterine serous carcinoma cases and 10 to 20% of uterine carcinosarcoma cases, making them susceptible to treatment with the monoclonal antibody trastuzumab. Although deficiency in mismatch repair is rare, 4 to 7%, tumors with this characteristic respond well to immune checkpoint inhibitors. Genetic sequencing using next-generation sequencing is recommended for recurrent or persistent disease to then identify molecular alterations and guide personalized treatment strategies. Expression of the estrogen receptor present in 20 to 60% of cases has generated interest in therapies targeting hormones, although clinical evidence remains limited. Immunotherapy is a promising approach for tumors with mismatch repair deficiency or high microsatellite instability, as they respond well to immune checkpoint inhibitors. Clinical trials named NRG-GO18 and RUBY demonstrate that adding pembrolizumab or dostarlimab to chemotherapy improves progression-free survival. For tumors with a functional mismatch repair system, which represents the majority of cases, immune checkpoint inhibitors alone have shown limited benefit. However, combination strategies, such as the use of lenvatinib and pembrolizumab, as evaluated in the Keynote 775 phase 3 trial, are being investigated.
Well, Manuel, thank you for giving us your perspective on this very high risk population. So obviously really exciting that are ongoing. So truly appreciate that review. I'm going to turn it over to Matteo Marchetti from the University of Padua. So, Matteo, what stood out as articles of most interest to you and why?
Thank you, Pedro, for this opportunity. Among the study presented in the special issue, one manuscript particularly caught my attention. Entitled Primary versus Interval Cytoreductive Surgery in Patients with Rare Epithelial or Non-Epithelial Ovarian Cancer.
Yeah, so obviously an interesting topic that often is not it's not frequently addressed. And what I wanted to ask you in clinical practice, one often has the question as to what to do for these rare subtypes. So whether to do primary debulking or start chemotherapy, can you share with us what you found out in this article?
Certainly, that's an issue. This study provides valuable insights into the surgical treatment strategy of rare ovarian tumors, focusing on two main subgroups: rare epithelial ovarian cancer, such as clear cell mucinous low-grade serous ovarian carcinoma, and non-epithelial ovarian cancers. For the first rare epithelial ovarian cancers, the study highlights the necessity of histotype-specific surgical approach, recognizing that these tumors exhibit distinct biological behaviors. Low-grade serous carcinoma demonstrate intrinsic resistance to platinum-based chemotherapy, limiting the role of neoadjuvant chemotherapy, even if complete growth resection is deemed not attainable. Endometrioid carcinoma exhibit variable chemosensitivity depending on tumor grade. So low-grade endometrioid tumors are typically diagnosed at an early stage and are often hormone receptor positive. In contrast, high-grade endometrioid tumors behave more aggressively, and their treatment mirrors the standard approach for high-grade serous ovarian cancer. Clear cell carcinoma is characterized by poor chemosensitivity, making primary cytoreductive surgery the preferred strategy whenever feasible. Due to the limited data, though, the study suggests adhering to the management approach used for high-grade serous cancer. And mucinous carcinoma is often diagnosed at an early stage and primarily managed with surgery alone. But in advanced stages, it has poor prognosis and is highly resistant to chemotherapy, emphasizing the need for complete cytoreduction. Studies on neoadjuvant chemotherapy efficacy report conflicting results, although, but primary cytoreductive surgery remains the preferred approach for this.
So basically, what I'm hearing you say is that one might want to start primary debulking for low-grade and mucinous. And as for non-epithelial cancers, is there any particular strategy for us to implement?
So when it comes to the non-epithelial ovarian cancer, treatment strategies are guided by 2018 ESMO clinical practice guidelines by Reiko Cardedal. While surgery remains the standard treatment, neoadjuvant chemotherapy can be considered in ovarian germ cell tumors, particularly in these germinomas, while exhibit high sensitivity to platinum-based chemotherapy with BEP regimen. Given that these tumors typically affect young women, neoadjuvant chemotherapy followed by intracytoreductive surgery may help reduce tumor burden and facilitate fertility-sparing surgery, for example. In contrast, sex-cord stromal tumors, particularly granulosa cell tumors, generally show limited responsiveness to chemotherapy, making primary surgery the most effective treatment. And finally, in small cell ovarian carcinomas, available data remains particularly scarce, and an optimal chemotherapy regimen has yet to be established. However, interval surgery does not appear to be inferior to primary, suggesting a potential role for neoadjuvant chemotherapy in selected cases.
Yeah, and thus the importance, of course, of having these cases presented in a tumor board and have a multidisciplinary approach to the management of these patients. So thank you so much, Matteo, for sharing the highlights of primary versus interval debulking in rare ovarian cancer. So then I'd like to turn it over now to Julia Gellison from the University of Wisconsin in Madison. Wanted to have you share with us what interests you most in this special issue.
Thank you, Pedro. I was particularly interested in the article Controversies in the Management of Serous Borderline Tumors and Low-Grade Serous Ovarian Cancer. So low-grade serous ovarian cancers are uncommon, accounting for less than 5% of epithelial ovarian cancer and are typically diagnosed in patients around 10 to 20 years younger than those with high-grade serous ovarian cancer. The authors note that our understanding of these cancers has been evolving largely just within the last 10 years, and most data that we do have to guide treatments are either retrospective or come from subgroup analyses of larger trials.
Yeah, and to that point, actually, Julia, I wanted to ask you because, there's always this question of the pathogenesis of low-grade serous. Is it different from high-grade? Are there any new findings that were discussed in these articles?
Yeah, regarding the pathogenesis of low-grade serous ovarian cancer, the authors discuss that while most are thought to arise from serous borderline tumors, there is evidence suggesting that some may arise de novo or from endosalpingiosis lesions that have undergone malignant transformation. Additionally, around 50 to 75% of low-grade serous ovarian tumors may have canonical MAP kinase pathway mutations or other pathway-associated mutations. There's also some evidence that there are different molecular subtypes of low-grade serous ovarian cancer, though, with those with MAP kinase pathway mutations generally having a more favorable prognosis and a higher likelihood of response to MEK inhibitor treatment than those with MAP kinase wild-type tumors.
Yes, there's a lot of excitement and interest in MEK inhibitors. Here at Houston Methodist, we're actually including trials using MEK inhibitors or combinations for low-grade serous cancers. Wanted to ask you, did the review also discuss on fertility sparing treatments in these cases? Certainly they're oftentimes are presenting early.
They did. So in terms of clinical controversies for low-grade serous ovarian cancer, they did discuss fertility preservation and that this is commonly considered for these patients, although there's limited data to guide decisions about fertility preservation. So currently, this may be considered for patients with stage 1A disease, and oocyte cryopreservation can be considered for those with more advanced stages. However, all patients should still have a complete staging surgery performed.
Yeah. And I wanted to follow up with regards to, obviously fertility preservation for low-grade serous 1A, it's fairly standard, but what about for advanced stages? Anything you want to add to perhaps even what Mateo was mentioning?
Similar to what Mateo was saying, for patients presenting with advanced disease, the authors of this article really emphasize that complete surgical cytoreduction can achieve the best outcomes. Therefore, maximal surgical effort should be employed. For those with unresectable disease at presentation, trials of neoadjuvant targeted therapies, such as a recent study of neoadjuvant fulvestrant and abemaciclib, provide promise that this may be an emerging avenue to decrease disease burden and make cytoreduction possible for more patients. Retrospective data also suggests that complete and optimal secondary cytoreduction confer survival advantages. However, in this setting, there are high rates of residual disease and high rates of postoperative complications from radical surgeries, which pose questions about the optimal candidates for secondary cytoreduction in low-grade serous ovarian cancer.
It's really interesting how fulvestrant is taking an increasing role in the management of these patients and certainly being brought to the neoadjuvant setting now. So, Julia, thanks for sharing your thoughts. And now we come to Medical University of Vienna with Thomas Bartel. So, Thomas, what stood out to you?
Thank you, Peter. I'd like to focus on a specific topic of debate that caught my interest in the article Controversies in the Management of Mucinous Ovarian Tumors. Despite exhibiting a distinct clinical behavior and specific molecular features which result in a relative resistance to platinum-based compounds, systemic therapy for advanced or recurrent mucinous ovarian cancers continues to be derived from data primarily focusing around the more common high-grade serous ovarian cancers. Due to the extremely low incidence of mucinous ovarian cancers, no prospective trial has yet established an evidence-based standard of care. Since the failure of the GOG-241 trial over a decade ago, which intended to compare the conventional carbotaxol regimen with gastrointestinal cancer treatment protocols, no further prospective trials specifically targeting mucinous ovarian cancer have emerged. Consequently, survival outcomes remain dismally low at approximately 12 to 14 months in advanced stages, with no significant improvement over the past decade, highlighting the urgent unmet need for more effective therapeutic strategies.
So now, indeed, of course, randomized trials have been difficult to obviously carry on in this particular scenario. So what are the new directions in the field of mucinous ovarian cancer? How are we studying these cancers?
Well, to address this particular challenge, molecular-driven precision medicine approaches appear to be the most promising path forward. Translational studies have characterized the distinct molecular landscape of mucinous ovarian cancers, which in a high percentage of cases is driven by alterations of the MAPK pathway. Unlike high series ovarian cancers, which are primarily driven by p53 mutations happening early during carcinogenesis. As a result, the genome of mucinous ovarian cancers remains relatively stable, and the tumor immune microenvironment is comparably cold, making these tumors unlikely to respond to PARP inhibitors or immune checkpoint inhibitors. However, MAPK pathway mutations present a potential therapeutic target, as do frequent HER2 aberrations. Early, albeit very preliminary data suggests that MAPK pathway targeting, such as through MEK inhibition, may be a viable option, while HER2-targeted antibody-drug conjugates could be promising in HER2 aberrant tumors. Evidence, however, remains confined to case reports. Today, we still far standards based on molecular-driven approaches. Implementing basket trial designs, integrating molecular profiling into clinical routine, and promoting multi-center collaborations could help to overcome these current limitations and approach a critical need to drive progress in the field.
Excellent. Really enjoyed those views, and thank you, Thomas, for your input. So a lot of new hope in targeting MAP pathways and the HER2 pathways. So thanks for sharing that with us. Now on to the University Hospital Heidelberg with Kira Fischer.
Yes, thanks, Pedro. So since the malignant ovarian germ cell tumors predominantly affect young patients, making their management, such as surveillance or adjuvant chemotherapy, a subject of considerable debate, this was the article that particularly caught my attention. Treatment guidelines for adult malignant ovarian germ cell tumors often rely on findings from the masculine counterpart, such as the testicular germ cell tumors or pediatric cases, because those are much more often. However, the tumors don't always exhibit similar clinical behavior, and therefore their management cannot always be directly extrapolated.
Yeah, so to that point, I agree. I mean, oftentimes the problems with some of these rare tumors is that we're extrapolating data from other types of scenarios, clinical scenarios, closest cohort, basically. A lot of these are early stage disease. Are there any considerations one should take for surgical management? Also, if you can give us some insight of the chemotherapy management for germ cell tumors, how are they different from high-grade serous carcinoma?
Sure, Pedro. The authors express concerns regarding the use of laparoscopy in malignant ovarian germ cell tumors due to the risk of tumor rupture or dissemination through morcellation and incomplete staging, which may hinder the accurate identification of stage 1A disease. So consequently, open surgery remains the preferred approach until further studies confirm the safety of minimal invasive techniques. And regarding adjuvant therapy, current guidelines recommend surveillance for stage 1A to C G1 immature teratomas and stage 1A dysgerminomas, while adjuvant chemotherapy remains standard for other histologies, particularly the yolk sac tumors or embryonal carcinomas, and also higher grade immature teratomas. A recent study suggests that surveillance may be a viable option for some stage 1A to C grade 1 to 3 immature teratomas, but further validation is still required. And the standard chemotherapy regimen consists of 4 cycles of BEP, so bleomycin, etoposide, and cisplatin, with some evidence suggesting that omitting bleomycin in the final cycle might help the reduction of pulmonary toxicity.
Yeah, so, and Kira, this is where the term of de-escalation comes into play, and many, obviously in the field of gynecologic oncology, are heading in this direction. Looking forward to new results on this. What about relapse setting?
Yeah, relapse is interesting because we have significant clinical differences between the masculine, the testicular germ cell tumors, and the ovarian germ cell tumors. While the testicular germ cell tumors have a survival rate in the relapse setting of 60 to 70%, the prognosis for relapse ovarian germ cell tumors is significantly worse, with survival rates as low as 10%. Still, second-line treatment options include TIPS, so paclitaxel, ifosfamide, and cisplatin, or VIIP, so vinblastine, instead of the paclitaxel. Targeted therapies aimed at genetic alterations, such as KIT inhibitors or PI3K targeted therapies and immune checkpoint inhibitors have not yet demonstrated significant clinical benefits. However, newer approaches, including CAR T-cell therapies targeting Claudin-6 or CD30, are currently still under investigation.
Great. So thanks, Kira. And, certainly in summary, I read this as malignant ovarian germ cell tumors are highly curable, but obviously present significant management challenges due to their rarity and the limited availability of really high quality data on these. So more centralized, specialized care, international collaborations are certainly essential to improve the outcomes and standardized treatment. And of course, obviously, following the standing guidelines. So now I want to take a turn and head over to Houston Methodist with Elise Yates. Elise, welcome. What stood out to you?
Hi, Dr. Ramirez. The title that interested me the most was the controversies in the management of ovarian granulosa cell and Sertoli Leydig cell tumors because of these tumors' unique pathophysiology and rarity.
So any part of that review that you would like to really highlight?
Yeah, so the authors discuss treatment recommendations, particularly for the fertility-sparing approaches. For the adult granulosa cell tumors, these typically present in the perimenopausal or early postmenopausal period. They're often unilateral, stage 1A, and associated with a good prognosis. In these cases, the standard treatment includes hysterectomy, bilateral salpingo-oophorectomy, omental biopsy, peritoneal washings and biopsies, and endometrial curettage due to the risk of endometrial hyperplasia. However, when these tumors present in the younger patients desiring future fertility, treatment decisions can become a little bit more complex. The authors do highlight the importance of shared decision-making in this population and also advocate for fertility-sparing surgery when desired, with consideration for adjuvant chemotherapy for patients with stage 1C disease due to their higher risk of recurrence.
So then now, wanted to ask you about the issue that we have in some of these patients. How do we follow these cases after treatment, and what is the preferred approach?
Yeah, so in terms for monitoring for recurrence, inhibin B is the most commonly used tumor marker for surveillance. However, this article mentioned that in premenopausal patients, anti-mullerian hormone or AMH is preferred due to fluctuations in inhibin B levels in this patient population. The combination of both markers may offer greater accuracy than either one alone. And in the event of recurrence, current evidence supports cytoreductive surgery for adult granulosa cell tumors.
Very good. Excellent. So thank you, Elise. And turning over to Christian Brown now from Switzerland, who wants to also highlight some of the articles that he felt were of most interest to him.
Hey, thank you, Pedro. I really enjoyed reading the article Controversies in the Management of Grade 1 and 2 Endometrial Carcinoma of the Ovary and Uterus. These articles thoroughly explore both the similarities and the differences between these two entities and their distinct molecular characteristics. For example, compared to the endometrial carcinoma, the frequencies of bull mute and mismatch repair deficiency are lower in low-grade ovarian cancers, while the p53 wild-type group is associated with excellent outcomes. ARITA1A and PIK3CA mutations are frequently observed in low-grade endometrial ovarian cancers and may serve as a marker predicting poor response to chemotherapy. Both show progesterone and estrogen receptor expression, which opens a potential treatment option for adjuvant or recurrent therapy.
Very well. And, Christian, sometimes we encounter synchronous cancers, endometrial and ovarian cancer. Are there any new findings on how we can better delineate the origin of these cancers?
Yeah, thank you. The article addresses this unique situation of synchronous primary tumors. Molecular profiling can assist in distinguishing endometrial cancer with ovarian involvement from true synchronous primaries. It has shown that the vast majority of these cases are advanced endometrial tumors with ovarian metastasis. Patients with real synchronous primaries have more frequently MLH1, PMS2 deficiency, and PTN aberrations compared to isolated low-grade endometrial ovarian cancers.
And Christian, another issue that I thought was interesting to discuss is, certainly although low-grade endometrial cancers have very good prognosis, they seem to be quite chemo-resistant when they recur. Any thoughts on that?
Yes, Pedro. The review underscored the limited data on recurrent disease, as low-grade endometrial ovarian carcinomas are rare, and recurrent or metastatic low-grade uterine carcinomas are underrepresented in randomized trials. Given its generally chemo-resistant nature, alternate treatment strategies are crucial. So the high expression of hormone receptors in these tumors makes endocrine therapy a promising option. With a phase 2 clinical trial of ribociclib and letrozole in recurrent estrogen receptor positive ovarian cancer demonstrating significant efficacy. As I already mentioned, PTM, PIK3CA, and ARIDA1 mutations are the key molecular drivers of low-grade endometrial ovarian carcinomas. Targeting these pathways with PI3K, RKT, and mTOR inhibitors has demonstrating promising results in preclinical models, highlighting their potential for future therapeutic approaches.
Excellent. Thank you so much for those insights, Christian. And now we'll turn it over to University of Toronto, Stephanie Gill. Stephanie, welcome again to the podcast. What article stood out to you, and what would you like to highlight about them?
So one of the articles that really caught my attention in this special issue was The Controversies in Vulvar Cancer, Revisiting the Margin of Error by Dr. Bird and colleagues. As gynecologic oncologists, we know that vulvar cancer is rare compared to other gynecological malignancies that we often treat. Its treatment does carry significant morbidity, and its recurrence can be life-threatening. So that's why it's so important to critically evaluate long-standing surgical and pathology principles for treatment, like the widely accepted greater than 8 millimeter tumor-free margin, and determine whether this margin status is acceptable to plan for re-excision or adjuvant treatment. So what really stood out for me in this article is the challenge to this historical standard. The greater than 8 millimeter margin has been based largely on small retrospective studies and expert consensus, rather than robust prospective data. Yet contemporary research suggests that margins smaller than 8 millimeters may not actually increase recurrence risk. The authors raise a crucial question. If not 8 millimeters, then what margin is actually safe? Again, with no compelling data one way or the other.
So then to that effect, and other than the actual size of the margin, are there any other parameters that we might use to indicate a higher chance of recurrence?
So I also think it's important to emphasize that they highlight margin pathology. They discuss emerging evidence that precancerous changes at the margin, like differentiated VIN or lichen sclerosis, might be more predictive of recurrence than the actual tumor-free distance itself. Therefore, should we have different treatment standards in these cases? Overall, this article underscores the need for well-designed prospective trials, which, as we know, are particularly difficult for rare diseases like vulvar cancer. The authors emphasize the importance of international collaboration, data sharing, and refining our approach to treatment to minimize morbidity while maintaining oncological safety.
Excellent. Thank you so much, Stephanie, for those insights. And now we're turning back to Houston Methodist with Clara Santilla. Clara, what were some of the articles that stood out to you?
Thank you, Pedro. The article that interested me the most was Neuroendocrine Cervical Carcinoma, Genomic Insights, Controversies in Treatment Strategies and Future Directions, a Nectar study. Dr. Gloria Salvo and the MD Anderson team did an excellent job summarizing what we currently know about this rare but aggressive tumor.
So then, Clara, of course, obviously, one of the natural questions is a lot of the treatment for neuroendocrine cervical cancer has been derived from neuroendocrine lung cancers. How are the cervix tumors similar or different from the lung cancer?
Neuroendocrine cervical carcinomas share features with both cervical cancer and small cell lung cancer. Phylogenetic analysis demonstrates that these tumors are derived from a common precursor shared with adenocarcinoma and harbor mutations typical of adenocarcinomas. In addition, HPV positivity is highly prevalent in this tumor, with HPV-18 being more common than HPV-16, similar to cervical adenocarcinomas. Despite these molecular similarities, neuroendocrine cervical carcinoma are far more aggressive and were histologically considered closely related to lung neuroendocrine tumors. However, recent genetic research has revealed key difference between them. Notably, mutations in P3K and MAPK pathway are present in 67% of neuroendocrine cervical cancer, with PK3CA being the most frequently mutated gene. These mutation rates align with other cervical cancer, but are rare in cell lung cancer and other neuroendocrine tumors. So this suggests that while neuroendocrine cervical cancer exhibit aggressive clinical behavior akin to lung cancer, their genetic profile is more closely related to HPV-driven cervical cancer.
So then, Clara, it's generally understanding now that genetically they're more similar to HPV-driven cancers. Could you break down for us what to do in the different stages of disease for neuroendocrine tumors?
Yes, of course, Pedro. For patients with early stage, treatment guidelines uniformly recommend radical hysterectomy and lymph node assessment, followed by chemotherapy, cisplatin, etoposide, or carboplatin, etoposide, but are inconsistent about recommendations for adjuvant pelvic radiation therapy. For bulky tumors greater than 4 centimeters localized to the cervix or extended to the upper vagina, the role of neoadjuvant chemotherapy is controversial and treatment guidelines are not consistent. NCCN guidelines recommend either chemoradiation or neoadjuvant chemotherapy followed by radical surgery and or definitive chemoradiation. Locally advanced neuroendocrine cervical carcinoma are treated with chemoradiation, concurrent radiation with cisplatin and etoposide, followed by additional chemotherapy for up to 6 cycles total. Adding immunotherapy to chemoradiation has been explored in other cervical cancer types, but not for neuroendocrine cervical carcinoma. For progressive and recurrent disease, treatment recommendations depend on the chemotherapy-free interval. If more than 6 months, the standard approach is cisplatin or carboplatin plus etoposide, and if less or equal 6 months, based on DOD 240, the Texas cocktail, topotecan, paclitaxel, and bevacizumab is a valid option.
Well, thank you very much, Clara, and thanks to all of the fellows who participated in this podcast. Certainly to our audience, thank you for joining us in this important discussion on rare gynecological cancers. These diagnoses, these conditions, of course, pose unique challenges in the treatment, ongoing research. It really is through the collaboration, innovation, and patient-centered care that we continue to make strides in improving outcomes. I want to thank you all for, again, participating. Thank you all for joining. If you found this discussion valuable, please share it with your colleagues and certainly stay tuned for future episodes. And I certainly encourage everybody to read all of the articles on the special issue of 2025 on rare gynecologic cancers.